a Canadian symposium. Um, um, so I did my training at the Hospital for Sick Children. That's where I learned my MEG. So some of the people here might be my previous mentors, colleagues, and friends. My goal of this talk is really just broadly about MEG. What are the scientific evidence behind its use in epilepsy surgery? What are the common scenarios where it's most useful? And what are the limitations that we hope that it can change over the years to help improve outcome in epilepsy surgery? Now, we are located, where I am now is in Alabama. We're in the southeast of the US, and we have quite a considerable catchment area. The color here indicates the areas where actually there is an MEG center. So we catch a significant portion of that southeast population, and we depend on it hugely for clinical care. Now, a couple of slides about MEG. This is a neurophysiologic signal. So similar to EEG, a tool that's non-invasive that measures neurophysiologic magnetic signals that comes from postsynaptic potentials. And instead of measuring the electrical field, we're measuring the magnetic field that's induced by this electrical current. And you can have different types of sensors that will pick up this magnetic field. They can either be a single coil, two coils that are next to each other, or one above the other, and the type of signal is going to be the same. What it looks like might be slightly different, in a way almost similar to when you look at an EEG, it's looking at a bipolar or a referential montage. Now, because this magnetic signal is very low, small, compared to anything else around it, then you have to have this very thick shielding that prevents any sort of external magnetic noise to come in the room. And also to have extra sources where you can eliminate this magnetic noise from affecting the recording. And I'll give you some examples for that as we go on. Now we use it because you have now a source localization from a signal that's coming from one area of the brain, and you have ways to co-register it with the patient's or the subject MRI, and you get what we call a magnetic source image. This is an image that looks like what you see in a functional MRI, but it's fundamentally different because these are sources that come from a neuronal signal. In order to do that, you will have two types of coils that you put in the patient when you record. One of them is what we call the head localization coil, and typically there are 5 of them. And this head localization coil serves to tell the system itself where is the head in relation to the sensor, and to make sure that the head remains still. If it moves too much, the coils will start giving you an error message, and if you cannot correct it, then the part of the data might need to be discarded. And the next part is to help you to co-register it with the subject's or the patient's MRI, where you put some fiducials. And these are pretty standard across centers, typically in the nasion, the right ear, and the left ear. And because of that, you can able to get any sources localized, the source of interest, localize a subject's brain. This case, for example, is a brain tumor. You can see where is the sensory cortex in relation to the tumor. It's a bit different than EEG, and people who do MEG will say, well, MEG is better. And there are reasons for MEG to be considered better than EEG. One of them is it doesn't have a reference. So unlike EEG, where the data might be contaminated by an active reference, MEG does not have a reference. And the second part is that magnetic properties of biologic tissues are identical. So the skull or a cavity does not smear out the recorded fields as in EEG. It has a better developed source modeling and MRI co-registration. And then the most important part is you really have a much larger number of sensors, which can be as high as above 300, compared to the limitations of putting how many electrodes you can put on a subject head in a way that can be tolerated for a sufficient duration of recording. And then you don't have contact with the scalp, which means that you're not going to see the effect of muscle artifact, for example, when you go and start looking at slightly higher frequencies with MEG, while you see that a lot with EEG recordings. A bit of the history: first recordings done back in the 1960s and 1972 by David Cohen. And at that time, it was a single sensor that allows you to record the very thing that we know about, which is alpha rhythm. So at that time, you can see the MEG recordings on the top part here. EEG is a bit low down, and you can see the similarity of that, what you see on MEG to what we know the most, which is the occipital alpha rhythm. As time went on, the numbers of sessions increased, the design of the room changed. This is the 80s, where you used to have 37 channels and you shift the head position depending on the area of interest. And then in the 90s, we started developing the whole head systems where the patient can lay inside and you're recording from the whole head. This is actually our old system, and this is Jeff Kellen, who's our MEG technologist. And this is a one that we had for the past 20 years, just replacing it with a newer model recently. There are a couple of things that determine the type of the magnetic signal. One of them is the source orientation. So if we know the physics, we have for every electrical field, there is a magnetic field that goes around it in what we call the right thumb rule. So if the magnetic right hand rule, so if the magnetic field if the electrical field going that direction, the magnetic field will be like that, which means that if you have something that is in the sulcal walls, you have a magnetic field that's going to be picked up outside. If you have something that's purely radial, then the magnetic field will be inside and you will not be picked as efficiently. MEG is probably not completely blind to radial sources. However, that location is way more favorable for MEG recordings than the top on the crown of the gyrus. And the second part is the magnetic signal decays the further the distance from the source. So if you have a deeper source, the less signal you go and pick up on MEG recordings. How is it recorded? Very similar to some degree to what we do in EEG, except the patient has to lay inside this helmet which contains the sensors, and we have to eliminate all sources of magnetic noise. Clothes, jewelry, hairsprays, some of the makeup. So we typically have the patient routinely change in a hospital gown, and then you put them on the scanner first to make sure that there is no source of artifact. And then there is a process of putting these head coils and digitization that makes sure that first, the head does not move during the recording, and if it moves, you know about it. And the second part, to make sure that they have a proper conductor model to do the analysis for it. And then there is always, with the newer systems, there's a continuous head monitoring, and in some degree, there is some compensation for some head movement that happened during the recording. And we have to depend on the signal-to-noise ratio. So all the localization accuracy will be highly dependent on the signal-to-noise ratio. So if you have sources that are nearby the system itself, elevators, power supplies, trains, cars, this can produce a magnetic noise. And typically, you know about this beforehand. It's the patient sources of noise that you will have to work on. In this case, you can see the noise coming from braces on the upper teeth. And you can find a way to eliminate this. Some of it are software-based, but you also have to try what we call a degaussing. And degaussing is basically eliminating this magnetic field that comes from it. And there are a bunch of those that you can find commercially. They're used to raise actually VHS tapes, for example. And you just basically have to rotate in a certain way along the area of interest and move it away, and that eliminates the magnetic noise from the area of interest. It should not be applied to VNS generators, pacemakers, or electronics. And with that, for example, and then if you don't have, if you have a source that you cannot degauss, like noise coming from a VNS, then you start applying software-based noise reduction algorithms, which basically divide the MEG data into subspaces, both in the spatial and temporal domain, one for the brain and one from the artifacts. And for example, you have a left temporal spike here. This is an MEG recordings before you apply any noise reduction. And you can have a software-based noise reduction that gives you a cleaner signal that you can use for source localization. So you can record most patients, except if you have a source in the brain that you cannot degauss and you cannot eliminate the magnetic noise from, which means something that's very, very close to the cortex. Cochlear implants are one, And programmable VP shunts, which actually have a processor inside, is the second one. You cannot do MEG recordings. You can record, however, you cannot get a data that's suitable for interpretation. And then there is some physical constraints, which mainly the head size. You have to keep in mind that the helmet can take a head circumference up to about 60 centimeters. However, if you add EEG electrodes, which we typically do for co-referencing, and you have to keep in mind that the patient will have to remain still enough for a period of time, then that limits how big of a head that can be put in that helmet. And typically in the US here, we ask the patients what head size they use. If they say it's 8 or 9, that's red flag. So what are the evidence of MEG use from prospective trials? There are a lot of data that I'll reference later on, but I'll just focus on the ones that came from prospective trials that came about 2006 and 2009. These are patients that we see commonly in clinical practice. These are the ones that will need an extra or additional modality to help localize where the seizure is coming from. So you exclude patients from with mesial temporal sclerosis, for example, who have a typical semiology and a classic MRI findings. And then you get the rest of the patients. You present them to a group of epileptologists. You come to a conclusion, and then you introduce the MSI data or the MEG data, and then you come up with the next how much the MEG data contributed to the decision making. Did it lead the patients to go into a direct resection? Did it change the decision for intracranial EEG, or excluded the patients from surgery completely? And if you look at these, there are a bunch of these papers, Robert Knowlton from 2006, 2009, Bill Sutherland in 2008, and all of them will give you almost about the same number. There is new information that comes from MEG in about 1/3 of the patients, and it changes significantly the surgical decision in about 1/5. It has a very high positive predictive value as you compare it to outcome, which is accuracy estimate, or intracranial EEG. A negative MEG does not tell you much. It has less significant in terms of its negative predictive value. This is data that was shared with the University of Montreal and gives you exactly the same outcome. Is that it makes a significant change in the surgical decision in about 1/5 of the cases. It can help you detect subtle cortical malformations. And more importantly, there is some stuff that we do in clinical practice makes you more comfortable about the decision making. Change the position of the grid, for example, to make the MEG cluster in the center of the grid rather than the margins. To put additional electrodes in areas that are not routinely sampled. Remove some of these electrodes that are in the time when you used to do a lot of strips, for example, that areas that were not thought to be part of the seizure onset based on MEG. For example, the mesial or interhemispheric region. But the more important is really sampling areas that are often unexplored: insula, orbitofrontal, and precuneus. And I'll show you examples of this later on as we go in the cases. And then you have these 1,000 cases from Stefan Ramp in Germany. And these ones show clearly how does a complete resection of an MEG cluster helps in terms of the final outcome. And you can see here a complete resection. We're talking about 10 years down the road. And you can see the chances of a complete seizure freedom is much higher than you have a partial or not resected at all. The specificity is extremely high, especially for extratemporal lobe epilepsy, and the positive predictive value is high for extratemporal lobe epilepsy. Now, we're all familiar with grids. This is SICKIDS exposures, which are huge, cover a large area of the brain when I did my fellowship there. And you can put marks that indicate where is a cluster of MEG, which part is anterior edge of it, the posterior edge of it, and the, for example, somatosensory cortex or any area of functional interest. And when you do that, these electrodes are next to each other. They have some spatial relation to each other that the signal has some gradient that you can understand. That's a bit different from what you do in a lot of cases right now, where we go with SEEG, and that will look considerably different than grids. There becomes a more importance of the precise localization, and I'll show you how much does that make a difference in where to put the electrodes. So this is, and I'll go on details about this one later on, but this is an insular case, and you can see two electrodes here that's showing a signal that's completely different from what you see, for example, an electrode in the middle of the insula. So if you don't put that electrode, if you don't put this one, you probably will end up by needing a much larger resection than you would for this case. And this was very clearly demonstrated by this paper back in 2016 from the Cleveland Clinic. If you put an electrode that transects this MEG cluster or cuts at the edge, it makes a huge difference in the patient outcome. Higher chance of being seizure-free when SEG is completely sampled the area as compared to those who's incomplete or no sampling, and that patients with one single type cluster on MEG were more likely to become seizure-free compared to patients who have scatters or patients who have only loose scatters. This is data again from University of Montreal, and this was unique in a way because the MEG data, even though it was collected before, even the data was collected before the surgery, they were not analyzed at the time because they were collected for research purposes. And then after the patients had surgery, and if some of them were failures, we looked at the data again, and it was interesting that some of these failures could have been easily avoided if the MEG data were available at the time of surgery. For example, this is a case for insular epilepsy, and you can see there's a bit of changes on the grid on the insular electrode that were not very sustained, and the more sustained rhythm was more anterior. So end up by having a frontal polar resection, and of course not seizure-free. It's only when this data were looked at, and this is really corresponding to the MEG cluster. He actually ended up by having a resection in that area alone, which made him seizure-free. Now, signal analysis. Clinical practice, equivalent current dipole. That's what has been validated over the years with all its limitations. And what it does is basically you try to model the area of interest, which is an epileptic spike in this case, with a single source. And you try to see the magnetic field that is projected from that source versus what you observe on the recordings. And you use that and you reject or accept that model based on certain criteria. And then you will get, you do that for every spike. You will end up by having something that's very tight and small like this, which means it's typically a small source that's producing all these dipoles. Or you have something like this, which is far widespread. And you have to do the clinical interpretation for this in the context of the patient itself. Is it a limitation of the source model, or it's actually a more diffuse source? If you have something like this, is what you like to see for a good surgical outcome. We'll show examples of the cases down the road. So, how is MEG used when other non-invasive? It's not a standalone test. And there is a lot of data to do how to look at MRIs after an MEG recording. For example, linking MRI post-processing with magnetic source imaging in MRI negative epilepsy. How does it correlate to 7T? And then the most important part is you look at this functional or structural data in the context of what you see on MEG. And I'll show you this, for example. This is a patient that's 3 years old with seizure semiology that's predominantly an ictal gagging, more or less. And we knew that localization is more likely coming from the left, but the MRI is hard to see anything. Looks completely normal. And the EEG has spikes that looks more temporal. MEG more towards the left frontal operculum. And then we go back and look at the PET, which was interpreted as negative at the beginning, and you can see the area of hypometabolism in this left frontal operculum. So this, of course, a case that will go for an SEG recording, and we tend to put a large number of electrodes around the area of interest. And it turns out a very small area here in the left frontal region that sits, you in retrospect, you probably can argue maybe there is a bit of signal change in that region and ends up by having a very small ablation and becoming seizure-free. So MEG alone in itself will just help you to look at what the other functional data are around and put this data together in helping the plan for surgery. The American Clinical MEG Society put a number of scenarios where MEG is going to be useful in in planning epilepsy surgery. And most of these scenarios are the common practice that we see on our daily epilepsy surgery cases. And these references are by no means meant to be a comprehensive review of all of them, but I'll go to some of these scenarios and clinical cases. How do we use MEG in epilepsy surgery? If you have multiple brain lesions on MRI, the best example is tuberous sclerosis. MEG can help you tell you which one is actually causing, the more likely to be the cause of the seizures, and that in conjunction with other anatomical and functional data. This is a 13-year-old, and you can see the EEG recording here. Seizure seems to be the spikes. Most of the spikes can be bilateral to some degree, but the majority of them seems to be more right temporal and probably mid-temporal. And they come in repetitive patterns, and the seizure seems to be evolving from them. Typically, what you see with MRI, you see a large number of tubers in these patients. You have one back here, one back here, one back here, one in front. And actually, it's quite hard to see there isn't one in the right temporal region, actually. But the MEG of these spikes is very much clustered around that right superior and middle temporal gyri. PET is bilateral, more on the right, quite diffuse, go very much posterior to the posterior part of the right temporal lobe. She had severe behavioral problems that every time we tried to do an SCEG placement, we actually were quite hesitant because of the risk of self-harm. So after delaying it for several times, we just decided, how about we go after the MEG cluster and find if there's a tumor in that area that we can actually resect and see if that might improve the behavioral problems to allow us to do a more tailored invasive epilepsy surgery later on. And you can argue that the right side here looks a bit more busy than the left. You cannot define its tuber very clearly, but there might be something here. So we went after the MEG cluster itself. And in the OR, we record, you put channels, electrodes anywhere. There are a lot of spikes everywhere around it. So we end up by doing an MEG clusterectomy of an area that felt like tuber-like in the OR. And interestingly, she came out within a couple of weeks, and these all very frequent interictal discharges completely disappeared. She's now seizure-free for about 3 months. Her behavior has improved significantly, and I feel we probably will need to do a second surgery at one time later on. But that's a case where it demonstrates how MEG can be useful when there are multiple lesions around that you cannot tell which one is the seizure is coming from. Recurrent seizures. And you can have a failure because either you have an incomplete resection, your hypothesis is long, or you have an insufficient impact. You did a limited resection with a diffuse epileptogenic zone. We published this in my days in Toronto back in 2007, and you can look at data based on the previous data from epilepsy surgery. So if you have something that's very, very small next to a previous resection, you can actually do an extension of the resection margin with or without ECOG. If you have something like this that goes and spans a bit more like 2 or 3 gyri behind the resection margin, then you have to make a decision based on what is the functional outcome from a resection in this area, whether you need a grid and functional mapping, or you can do it just based on ECOG if it's away from functional area. If you have something like this, which is bilateral, diffuse, multiple areas, diffuse, temporal and occipital, then obviously you need to revise your hypothesis and do another second invasive monitoring. So this is a 3 years old, start having seizure around 13 months, and they were predominantly, have a temporal lobe semiology, staring, not responding, with a very rare focal to bilateral tonic-clonic seizure that are long, last about 10 or 15 minutes. First time we did him, he had right left anterior to mid-temporal spikes, but he also has very rare that we're seeing only in the SEEG on video EEG monitoring that comes from the posterior head region. And at the time, we did not know the significance of this. We probably say maybe coming from the base of the temporal lobe, and we just put electrode there. The seizure themselves look mesial temporal. Or at least anterior temporal. They have a very broad field across the temporal region, but they seem to be more anterior. So, and the PET was diffusely on the left. That goes back from the tip of the temporal lobe to the very posterior part of the left temporal lobe. There is a bit of left mesial temporal sclerosis as well, with asymmetry seen here on the left mesial temporal structure, smaller and higher signal. So the first SEG would say, well, okay, maybe anterior temporal, mesial, base of the temporal lobe, and a little bit of the parietal region. And ictal onset was not very conclusive, but there was some suggestion that might be, coming from that base of the temporal lobe. So the first resection was directed at the base of the left temporal lobe. Came out a couple of weeks later with a generalized tonic-clonic seizure. Then we did that's where the MEG was useful. We did not do the MEG the first time. Now MEG this is the second time, and you can see here some that are coming from the left mesial temporal lobe, but the main cluster sits very, very back in the occipital, the base of the occipital lobe, in an area that was not sampled the first time. We do a lot of averaging, and you can see here, this is the EEG source localization, which sits a bit more higher up in the parieto-occipital junction, and the MEG source localization of average spikes, which is the very base of the occipital lobe. And you can see the time difference between how the MEG spikes precedes the EEG spikes by very small, about 10 milliseconds between the two. So the second surgery really had a very much sampling of that MEG cluster, electrodes that go through it. And indeed, it was a very small number of channels. You can see it here. D is purple, E is orange. It was a very small number of channels where the MEG cluster was. We record EEG routine scalp electrodes with the SEEG. And you can see, even when we're seeing spikes in this very small number of channels, there is really nothing on the scalp EEG for a long period. Seizure evolved from the same contacts. And then this is where it starts. This is where the clinical onset is. Almost about 5 minutes, where you see only spikes in a very small number of contacts where the MEG spikes are. Stimulation confirmed the same findings. This is again the purple electrodes here, D6 and 7, and end up by having a very small resection in the base and very much the very posterior part, or the base of the occipital lobe actually, and end up by becoming seizure-free. This is actually quite a nice case because without putting an electrode in that area, you probably will end up by having to resect a spread pattern in a dominant hemisphere, and subjecting the patient to become not seizure-free and to functional deficits. A large abnormality indicated by other investigation. This case is we just have done this one very recently. This is again a 13-year-old, and you learn from your mistakes the first time. I'll show you how this relates to the one before. Has started having seizures around age 18 months. Again, semiology is focal with impaired awareness, predominantly temporal with some unusual features, and she has also generalized tonic-clonic seizures. EEG right side. This is again right temporal chain here, and you can see the EEG abnormality, broad, sharply contoured activity that's rather semi-periodic. That's not exactly anterior, maybe towards the middle or posterior part of the temporal lobe. And her PET, a very diffuse changes that across that right temporal lobe. SPECT localized to the very anterior towards the pole of the right temporal lobe, and she has a smaller right hippocampus with slight signal, smaller right hippocampus, slight signal changes compared to the left. MEG is very posterior. So that's with the beauty of having these MEG spikes and doing source localization. Very much similar to the case before. And the averaging shows it very, very much the very posterior of the right temporal base. So this time we'll learn it, and we put electrodes right from the beginning through that MEG cluster, going into the temporal, going into the very much the anterior part of the right temporal lobe. And you can see here, the onset is nearly simultaneous. This is the S1, S2. These are the electrodes that are actually inside the mesial temporal structures. This one is very much at the base of the right temporal lobe, posterior part, overlaying the MEG cluster. Almost simultaneous. However, when we did the stimulation, habitual seizures came from only that right area. She ended up by having a resection that involves this part as well as the anterior part of the temporal lobe. Ancillary reflex is another scenario where we don't think MEG is useful because the insula has a rather smaller gyral structure that's a bit of a deeper area of the brain. So you think it's not going to be able to generate a large magnetic field, and also because it's deep. But it turns out not to be the case, because all this ancillary activity will typically propagate along the part of the Sylvian fissure into either the very anterior or very posterior part. And you can be able to do source localization very simply on these spikes. And if they are MEG only, then you typically see them in the insula. If they start having a field involving the temporal lobe as well, and start seeing them on EEG, they tend to localize actually in the temporal lobe. So you're looking mainly at these very small, tiny spikes that you see only on EEG, on MEG. This is a 16-year-old. And again, the seizure semiology here is a bit similar to what you expect from insular epilepsy. Zones out, blank stare, take a deep breath, has left or bilateral hand numbness, feeling hot or cold. So there are lots of features that suggest the insula might be involved. They are frequent, very short, and the impaired awareness is the main part that puts seizure burden on him. MRI is normal. Spikes are, you see this very commonly in insular epilepsy. Very small, very tiny. You can see them sometimes on MEG only. You can see them with EEG at times. And they are typically either F8 or F7. So F8 on the right hemisphere or F7 on the right. These ones you can see, this is the right temporal chain. And you can see here very small, tiny spikes. PET, more or less normal. You can't see anything in the insula clearly on the right side. And MRI is completely normal, and SPECT was unsuccessful mainly because the seizure is very short. Now, MEG loves these spikes. They're very small, they're very narrow, and they localize very much typically to the anterior part of the anterior perculainsular region. They have a very characteristic orientation, and they have very characteristic topography. And this is, again, average spikes. So this case, implantation was primarily based on semiology and the MEG data. And you can see here, I showed you this earlier, there is nothing coming from the mid-insula. All the spikes are coming either from that very much the orbital part of the inferior frontal gyrus, superior insula, and the anterior insula. So stimulation of the superior insula gives you very much a habitual seizures, habitual semiology. Stimulation from the orbital part of the inferior frontal gyrus also give you something very similar. Again, you can see this here. End up by having resection in this area, sparing the mid-insula, completely seizure-free for 3 years now. Suspected intrahemispheric onset is another one. Again, most of these are very difficult cases, mainly because they spread quickly. So you get a very quick tonic component, and sometimes you don't see even an EEG lead. So unless you put electrodes exactly where they're coming from, it's going to be very difficult to define where the seizure is coming from. This is an example. You have the field here, spikes that are central, but also have a bilateral field. And you can't really tell from the ecta discharge. PET, a bit more diffuse, coming back very posteriorly on that left hemisphere, slightly extending just in front of the central sulcus. MEG spikes localize very nicely to that very small area that were not picked up originally, that likely a cortical dysplasia, which sits right in front of the motor cortex. This is the average spikes, again, right in front of the motor cortex on the superior part of the, just in front of the of the left precentral gyrus. Again, MEG dipoles are here, and we do pneumatic stimulation for somatosensory mapping. So you get a nice area of where thumb, big toe, sensory areas are. You can use that at the time of surgery. We implanted him bilaterally just because we had some suspicion there might be something coming from the other side as well, but the main implant was on this left side. And you can see here that might be an area of cortical dysplasia in this region. And the MRI was and the electrodes actually were very nice because you see this positive phase reversal, which tells you that these two are literally on two sides of a gyrus, which transects the MEG cluster. So again, you put all these data together, corticospinal tract mapping from DTI, somatosensory fields, the MEG, the dipoles between the MEG dipoles as well as the electrodes, which really has defined a very small area here, and basically an ablation rendered him seizure-free. Ectal MEG is another one where a scenario where MEG is very useful. And actually, if you look at the data, there are a lot of recordings that you can obtain for seizures during our routine MEG practice. So a 51-minute MEG or a 2-hour MEG recording or a 60-minute MEG recording, you can get almost up to about about 10% of cases to have a seizure during an MEG recording if properly planned. So careful selection of patients, more prolonged recording while optimizing patients' comfort, sleep depriving them, reducing anti-epileptic drugs. You make the timing proper. If patients have seizures, once they fall asleep, you make sure that you sleep deprive them, put them in a scanner, and hope to get a seizure within this 1 hour. And then sometimes using specific triggers. And the commonest scenarios for this is reading, reflex, or musicogenic epilepsy. And the good thing about ectal MEG data now is that with continuous head monitoring, you will know when did the head move. And a lot of times you're looking at that part of the MEG data that precedes the clinical onset and the head movement, which you can do source localization on. And you can tailor now these are typically not spikes that will have a huge signal to noise ratio. So you can tailor an analysis based on the type of ectal discharge. So if you have repetitive spikes or periodic discharges, you can do an equivalent current dipole model on it. And that typically would localize to the center of what you see on interictal discharges. So you have more of an ectal onset that localizes a small area compared to a wider relative zone. If you have low amplitude fast activity or rhythmic high frequency activity, then this will have to tailor your analysis method based on the time of discharge, and there are different papers that describe different methods. The key part is that you have to understand the mathematical model that you apply. And then you have to define in a starting point what you use as a baseline, what frequency band you do the analysis on, and how long is that epoch that you analyze. And then how to threshold the data to make sense of these findings. The key part is ectal onset has to stay stable for a period of time to be considered reliable. So it's not like 5 milliseconds at the beginning. You have to see it stable in the same location for at least 2, 4, 6 seconds after the onset. So it's more useful if you have a high frequency of dating seizures. You have multifocal interictal discharges, but one seizure type, and you hope to catch a seizure that represents that one seizure type, non-convulsive status epilepticus, or if you have rare or no interictal discharges, mesial front or interhemispheric localization is one common scenario. And this is an example of this. This is a reflex epilepsy that's induced by noise. So you can easily induce it in the scanner. And all what you're looking at is this very small part at the beginning, which is about maybe 2 or 3 seconds, that before the movement artifact covers the whole recording and make it very difficult. So you're looking at these repetitive periodic sharp waves at the beginning. You can average them, or you can do current source density, and it will give you some indications. This might not be the most reliable because the duration before movement is short, but give you some indication that you can use. And this is a case where you needed bilateral implant, dense, heavy, very diffuse, even on the SEEG. However, stimulation give you an identical semiology and end up by having a very small resection and became seizure-free. Okay. There are other methods that you can use. Non-convulsive stats is another one, and this is a software developed by Dakshin, Brainwave, which is very suitable for these low amplitude fast activities. Sometimes you see in patients, if you have patients who have frequent seizures, you can see this, and what you do is basically calculating a power at every millisecond, and then combining the power across a time period, say a 1 second, for example, and see where the maximum activity is. And if that's stable across time, verified by what we call virtual sensor recording from these areas, and you can feel more comfortable about the source localization. So when and why will MEG fail? Sensitivity is a big thing. MEG is very sensitive to areas that are large sulcal walls. So, for example, sylvian fissure, superior and middle temporal sulci, central sulcus. These are areas where MEG is very useful. The more deep you go, and the more you come on the crown of the sulcus, or if you have something like a polymicrogyria where the sulci are very small and cannot generate a uniform magnetic field, then MEG might fail to estimate where the seizures are coming or the interictal activity is coming from. There are a lot of other things as well. ECG model is time consuming. It's not a realistic estimate of the source. It's highly dependent on signal to noise ratio and subjective interpretation. And the more important part is it's not meant to provide a true estimate of spatial extent of the source. That's why it's mainly used for targeting and rarely used as a resection alone, as a method for defining resection on itself. We did that. Again, that's software developed by Dakshin. And this is basically just looking at spikes, using them one after the other, power, and then averaging all of them together. And you can get a quick estimate where the interictal spikes are maximum from. Shortening your analysis time, still, it needs a subjective component to it because you define the spike, you define where you do the power estimation. There are other methods as well that has been trying to cut down to actually define the spatial extent of the source. Now, none of this is validated enough. Some might be better than others. It's an area that probably might improve the yield of MEG as the software methodology and the computational methods improve. This is a paper from Christoph Grova group in McGill, looking at different source analysis methods, which one would fit better with where the actual resection is. Another paper from Boyot et al. From France, trying to estimate, can you get an estimate of the actual source region to help you to guide which area to resect. And then we have the problem with scatters, which might mislead. This is a paper from Hiroshi's group in sick kids. And you can sometimes see spikes that further away from where the lesion is. And you have to keep that in your mind when you redo your analysis. Okay. I'll go I have a few minutes. MEG is used also for other functional mapping, somatosensory cortex, language areas, visually evoked fields. If you have pneumatic stimulator, then you can actually map each finger separately and the lip. For example, this will be the lip area, and then as you go up, you can map the homunculus. If you have electrical stimulation, then you're primarily mapping, typically the thumb. Language areas, this is the old Papanicolaou paradigm. And the good thing about that is that MEGs actually can give you, this is an auditory word receptive language task. So you basically try to stimulate receptive language areas, and typically you can do, this is based on maximum entry of the meme, which is part of the brainstorm toolbox. And you can see at the beginning, bilateral, and then once you start going into the receptive language component, then you start seeing a predominantly left-sided activation. And you can look at the sequential activation of different areas of the brain, how they communicate together to help you define used mainly for language lateralization, but there is an element as well that you can use for localization if you have the proper algorithms. So I'll stop here. I hope I showed you that there is strong evidence to support MEG use in the workup of epilepsy surgery. It can be very variable in certain groups of patients, and the future of it will be enhanced by the new computational methods as well as hardware developments. I've been in different places across my career. A lot of where I learned MEG comes from Toronto group. Dr. Otsubu, my collaborator, Dr. Shane. I had a lot of data from University of Montreal, and I'm very grateful to Dang Nguyen for sharing this data, and then our own epilepsy group at UEB, as well as engineering and computer science faculty and students who come and rotate the labs, do some sort of improving source localization methods or co-registration for EEG electrodes. And I will stop here.